Welcome back. This is episode 43 of the Med Edit podcast, your go-to resource for evidence-based medical education.
And the only podcast where two board-certified physicians break down health myths, explore science-based strategies, and bring you the answers you need.
Today, we have an extra special guest, board-certified integrative ENT, Dr. Jessica Lee, also known as @ENTChat on Instagram. She is also board certified in lifestyle medicine, and she's going to be breaking down some interesting facts about sinus headaches versus sinus infections, the overlap between migraine, allergies, and actual infections, concerns with antibiotic overuse for sinus symptoms, and what listeners can do to get some relief finally.
Sounds like we have a lot to cover, so let's get started.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit podcast. So just for our listeners, over 80% of sinus infections, diagnoses, or complaints are actually misdiagnosed and are one of the most common complaints seen by primary care physicians like me. We are excited to discuss this information much more with Dr. Jessica Lee today. Welcome to the podcast, Dr. Lee.
Thank you guys, Jessica and Carrie, for having me, and please call me Jessica. I'm excited to be here, and I think we have a great discussion ahead.
I have loved personally following your social media content, and I think that really the best place to start is to let our listeners know what's really the difference between an integrative otolaryngologist and how does that differ from kind of a traditional ENT doc?
First of all, well done. Otolaryngology is a really hard word. When you go through the match and you have to, in the old days, right, you had to get up and read in front of everybody. And I was terrified I was going to mispronounce otolaryngology. Anyway, but yeah, ENT.
Too much pressure.
You feel like your hands are shaking. Okay, so what's the difference between traditional and what I do, which is integrative? So obviously traditional ENT is you've done your 4 years of medical school, you match in the 5-year surgical residency, and you complete that. You maybe do a fellowship afterward in a subspecialty, and then you go out into the world and practice. And of course, there are, many very well qualified ENTs across the nation whom I have the pleasure of working with. I decided to take it a step further, and about 5 years ago, I actually sat for the boards for lifestyle medicine, which is a branch of medicine that really pulls in things that we really didn't get taught in medical school, things like nutrition, physical activity science, sleep quality science, stress management, emotional connections. And it really talks about how critical these are from a daily health standpoint, and also how they impact like the rising rates of chronic illness that we see in our nation. Then, because, I'm a classic type A overachiever, I decided to take it another step and just did a lot of courses on my own in integrative medicine studies, herbal medicine, and really just started to learn more and more about different ways of approaching some of the most common symptoms we see that maybe modern medicine or modern conventional medicine isn't so great at understanding or dealing with. And the bottom line, honestly, is it just gave me a bigger toolbox, which is wonderful when someone walks in my clinic.
I love that. I actually have all the stuff I'm supposed to sit and take my lifestyle boards at some point in time, but had a baby and got a little delayed there. But I have total respect for that and love how it can be an added modality to the true, medicine with its evidence-based, but add these modalities to really just add in another perspective. And I guess perspective is the wrong word. Just add in another way that we can truly help the patient achieve their best health.
And Jessica, I think perspective is an okay word, is a good word, because honestly, what I tell people is ever since going through that additional training, it's like taking blinders off. And you see things differently. Like when the patient walks in the door and they describe their symptoms, you start to see it in a different light. But like I said, it really just comes around to having more opportunities to discuss more options with your patients.
Yeah, I think like even for me, one of the things that I have now found myself doing when I have a patient, let's say who's a diabetic and they're non-compliant. And so instead of just writing, won't take their medicines, non-compliant, I actually will sit there and we'll have much deeper conversations about mental health, nutrition, access to nutrition, maybe what they grew up understanding about foods and nutrition and exercise. And I'll sit there and just have a conversation that maybe somebody else will be like, why did you waste your time on that? Well, then they come back 3 months later, 6 months later, and they're so much better. Maybe they can afford the medication now because we've also addressed maybe some underlying mental health needs and things. So I do think it's a great way to add it into your practice and still maintain, the really evidence-based care. So we're really excited to talk to you about all this today.
Yeah, awesome. Love it.
All right, well, let's get into it then. So, okay, a big, over branch, and I love on your Instagram, you talk about how terminology is kind of skewed or not entirely accurate. But okay, chronic rhinosinusitis. What is it? Why is it not all types are the same? And, how do you really kind of tailor the treatments based that you may recommend based on the type?
Right. So chronic sinusitis, just like you guys, I'm sure, think of in your specialties, chronic usually means sustained over a period of time. And in this case, we're talking 3 months. Rhinosinusitis, when you break it down, really is just nose and sinus inflammation, right? But there's definitely, I think, a misconception when someone says sinusitis that it automatically
Mhm.
equals infection. And I think that's where we get
Right.
in
Mm-hmm.
trouble. Because what we are beginning to understand more about is that chronic rhinosinusitis is much more an immune system breakdown or dysfunction than just an infection problem. So the cardinal symptoms, there's four main symptoms that we talk about when we talk about either acute or chronic rhinosinusitis. And that's going to be nasal congestion, but I kind of don't like that word because congestion means a lot of different things to a lot of different people. So when I'm in clinic, I usually say, how do you feel when you breathe through your nose? Like, is that airflow comfortable for you or does it feel blocked? Is usually the way I'll ask that question. And then nasal drainage. And again, people are going to tell you whether it's front or back, post nasal drip. Is it purulent and nasty looking or is it just clear? Facial pressure or headaches, and then reduced sense of smell. So those are those four symptoms. And you have to have some combination, more than one of those and then over that 12-week period to kind of meet that definition for chronic rhinosinusitis. And then, of course, like I said, it's not all due to the same reason. We now understand that there is so much to do with your nasal and your sinus passages acting as kind of a local protective barrier. And if that breaks down, you may be more susceptible to infections. So infections can be almost secondary to that immune or that mucosal barrier breakdown. And that's why it's important to understand, because if someone just comes in and they meet, they tick off 3 of 4 of those symptoms I mentioned, it's not as easy as an algorithm to say, okay, here's your antibiotic, here's your prednisone, see you back in 3 weeks or something. You really have to think about, could it be allergies? Could it be an immune deficiency? Is it a persistent infection? And if so, where's that infection coming from? We see a lot of patients with dental or odontogenic sources that can linger. So you really do have to kind of have that conversation, like you mentioned earlier. It takes time to sort through a patient's history and figure out what's really their underlying cause. And then you know how to treat it, right? You know how to guide those treatments to that.
That makes a lot of sense.
Yeah.
I know. I think that we see that, especially in the primary care world. And then it's, everybody just wants to come in and they beg for an antibiotic. And they say, it's chronic. I always have them, or they just kind of almost schedule it. They're like, I'm going to come in at this month, and this month so that I can come get my antibiotics. And we're like, you're planning that out ahead of time. Are we sure that's actually an infection? Looking at it from an immune system response and the lining, it sounds like the best approach to it, of course. But one thing you also talk about that I find really interesting is the shift over the last 20 years in ENT research into the underlying cause of rhinosinusitis. You kind of were talking about that already with the autoimmune portion of it. But when we're talking about treatments with that, what do we look at?
Sinus infections often begin with a viral trigger, right? We know that a lot of times you get sick, it's probably a virus. And in some cases, that can turn into a secondary bacterial infection. But really, the other piece that's happening behind the curtain is an immune response. And what we always hope is that immune response comes in, does its job, and then leaves again. And the problem is when that doesn't happen, when it's either an exaggerated response or it's a response that is sort of maintained over months or even years for some people. You end up getting remodeling of the nasal and sinus mucosal lining. So you may get, for instance, an increase in goblet cells, which means you're more of a mucus producer than you were before. You may have blockage of the sinus drainage pathways, so it creates an anaerobic, low oxygen environment, which is going to change what bacteria tend to thrive. And so it really, again, kind of comes back to understanding what's everything that's going on behind the scenes with the immune system as well. It's interesting because I even got to see some of this progression in training over, a decade ago, where there were some studies that came out probably 20 years ago, and they thought, oh, it's fungus. Fungus is the problem. We inhale these spores and it creates all this problem. And then studies didn't and treatments didn't really pan out. So then it moved on to its, staph endotoxin. And then those studies didn't pan out. And then it turned into biofilm, right? And then it turned into this other thing. And none of the sort of infection pathologies have really panned out to be, all that helpful. I mean, again, those are possibilities, but oftentimes they're secondary, or maybe we'll call them co-primary, but they're not the only thing going on. So we kind of now talk about it. You may hear people talk about chronic sinusitis with or without nasal polyps. And again, even that's kind of falling out of vogue. We now talk about type 2 inflammation and non-type 2 inflammation. Type 2 is going to be your classic like eosinophilic cytokines like IL-4, IL-5, IL-13. This is, people who have nasal polyps, they have allergic rhinitis, they have asthma. That's one sort of class of chronic sinusitis patients. The other class is a little more infection, focused. So it's more neutrophilic. It involves different cytokines. These patients tend to be more susceptible to bacterial biofilms. They're often at risk because of a lot of more environmental factors, whether it's like workplace exposures or, water damage, building mold exposure, things like that too. But being able to kind of put it into those categories helps us understand, is antibiotic an appropriate, course, or are we needing to consider, something like allergy, immunotherapy or biologic therapy or something else?
I think that's a good point to bring up too, because I often do have patients that get very worried about fungal infections. They're like, or they're like, there's mold in my house. Yeah. I'm ridden, I'm covered in mold. Like we need to like flush me out in my sinuses with mold. If a patient comes to you with that and they're saying, I just have this inflammation here and it's got to be from molds, there are cases obviously that do have it, but how do you distinguish between that or do testing? What do you talk to them about?
I usually start with explaining what that means and explaining that, our sinuses and our nose are not sterile environments, and we have mold species that are found in those spaces naturally. So to just do a culture on someone and then tell them it comes back with a mold is not sufficient and inappropriate, honestly. We do know, and then I'll kind of usually walk through, we do know there are certain types of sinus illnesses that are focused around fungus. So things like mycetoma, which is a fungal ball, allergic fungal sinusitis. You can have invasive fungal sinusitis, but that's very rare, thankfully. And so I usually kind of describe like, here are the fungal sinus diseases that we really understand and know a lot about. And then, their questions often get into a little more, topics that aren't as evidence-based, we'll say. And I usually just try to say, we can certainly consider that as a possibility, but there's a lot of other things on this list we also need to consider that have not been ruled out. I think the tendency is, people have seen something online and they kind of come in and they kind of jump to that conclusion that that's what it must be without realizing that they may have allergies, it may be something in their diet. It may not be their sinuses at all, right? I mean, we started this podcast saying how 80% of people are actually misdiagnosed. And so many times I see patients who come in who have this history. They'll just tell me, I've always had sinus issues. I get sinus infections 2-3 times a year. I get on my antibiotics, all this stuff. And I say, next time you feel sick, I want you to come in and see me. And we do the exam, we do the endoscopy or the CT scan, and they have no sinus disease. And so then we have to kind of, it's a game stopper, their mouths drop open, and some people have gotten honestly mad because they're like, but I have sinus issues. And I'm like, let's consider that it could be not a sinus issue, just for kicks, like try it, hear me out, but it's tough, it's tough to for someone to realize that, they may have been misdiagnosed in the past. And so it's not about calling out other people's mistakes or anything. It's about getting people the relief that they're really searching for.
So we've talked about our love for evidence-based integrative or complementary treatment options on the show. We've done that in another episode previously as well with one of our rheumatologists, but we love to talk about this. So for you, talk to us about the data behind things like acupuncture, red light therapy, sauna use, maybe some herbal supplements and other integrative therapies that are helpful for the sinuses.
Let's start with the most sort of evidence-based or evidence-backed. And I would say that acupuncture probably fits in there. Now, acupuncture, sticking yourself with tiny needles, is not everybody's idea of a good time or relaxation, but the evidence for it is strong enough that it actually is part of our AAO HNS, which is our like National Society for ENT. it is actually part of the allergic rhinitis treatment clinical guidelines as an option. It's not a strong recommendation, but it's in there as at least an option, which is a big deal because those types of guidelines, as you know, go through really, really scrutinous review before anything's put in them. So to me, that's always something I think that people can think of, again, as an add-on. I wouldn't claim to tell people like, hey, all you need to do is acupuncture and it will cure your allergies and you don't have to do anything else. But if I have someone who's kind of maxed out medical regimen or they're on allergy shots and they're just not quite feeling as good as they hope to, those are times when we'll bring in that kind of discussion about, well, here's something else we could consider if you wanted to try it. I think the next step down or the next thing that I like to talk about are herbal supplements. Again, there's actually pretty good evidence to support several different formulations of herbal, components. There's one called pelargonium, which is African violet, I think. And it's a tincture. It's really easy to take. There's a great over-the-counter version. And it has been shown in multiple studies to reduce your severity of symptoms and how long you're sick when you have a true acute, like viral or even bacterial sinusitis. So again, it's not like that's the only thing you do, but maybe it's part of your regimen in those first few days when you realize, hey, this is starting to come on and I'm trying to avoid needing an antibiotic. There's other ones too. The sad thing is, like in the US, there's not access to some of these. I actually love the European guidelines for sinusitis because herbal medicine is part of their acute sinusitis guideline. But they also have like some really great products that it's harder to find in the US. So that's always, something to consider too. When you look at, the more trendy things, sauna, red light therapy, things like that. And it's a little bit tongue in cheek that I've posted about things in the past. There is 1 or 2 studies on these, and it's exciting. And we certainly know there are benefits for red light therapy and for sauna and other parts of our health. So the idea here is it's not really, again, it's not like I'm going to prescribe someone to just go use red light therapy for their sinus infection. Absolutely not. But if they want to try it, I'm up for it. Let's talk about how to use it safely. Let's talk about what consistent use looks like, and let's reevaluate in a few, weeks and see how you feel. Right. It's not something that is, going to be in our guideline anytime soon. But again, patients are interested. They want to understand what's the evidence behind this. And I think having the conversation with them and being open-minded basically nurtures that relationship with your patients. They're going to keep coming back to you for information and for future treatment. And, you're just going to build that trust a little more efficiently.
Yeah, absolutely. And I think that that's a really great point because there is so many things that trend that our patients come and ask us about. And they sometimes seem frustrated that we can't always give them an answer on if it's helpful. And I've just kind of adopted the line that I don't know if it works, but I don't have any evidence that it's harmful. So if you want to try it, I don't have any evidence it's going to hurt you, but I also don't have the evidence it's going to help because it doesn't exist. And it seems to give them a little bit of reassurance that you're not brushing them off and that if you could give them any more data, you would. And sometimes it's just not there.
100%. I think that's exactly the way, that to approach it in a way that encourages the conversation, doesn't make people feel like they're being brushed off, but you're being honest. You're still being very evidence-based to say, I don't know, there doesn't seem to be a downside, but we don't really know enough to know that there's definitely an upside.
I think this next topic will probably interest a lot of people. We're talking about tongue in cheek, but especially for those with chronic headaches. So tell us about the quote, sinus headaches, end quote, and why that may not be the correct diagnosis for some people.
This is probably, when I talked about taking blinders off, this is one of the main things that I started seeing every single day in my clinic. Is someone comes in and their, the MA goes in and they gets the history and their complaint is often sinus headache. And that's not really, technically there's an ICD-10 that is attached to those 2 words, but that ICD-10 code also encompasses like every other version of sinus complaint you could have. So it's not helpful. But the point is people are having this pain or this pressure or this fullness in their face. And a lot of people don't interpret that as headache. They interpret it as sinus because they've been told, well, that's where your sinuses are, which is true. That is where your sinuses are. The problem is just because you're having pain or pressure in that location doesn't equal infection. Again, it's back to that. You can have a sinus headache, but it doesn't mean it's a sinus infection problem. And that's where I think things go wrong is because people will, present, they'll say, I have a sinus headache. I've got a little congestion or postnasal drip. And the assumption is, it's an infection, here's your antibiotic, and they feel better in a few days and they think, well, great, that antibiotic worked, I know what works for me. And you'll hear people say that, right? You guys have people come in, they go, I know what works for me, just give it to me. And you're like, well, can
Mm-hmm.
we just like have a conversation?
Mm-hmm. All the time.
Yes, right. The problem is, so there was actually a study in JAMA, and this was actually like a study from 15, 20 years ago, where they looked at people who came in with a main complaint of sinus headache, and then they actually did the appropriate like workup, whether it was a nasal endoscopy or CT or whatever it might have been. And 88% of people who had recurrent sinus headaches as the primary complaint actually met criteria for migraine. But if you tell people that, again, mouths drop. They will even potentially get a little upset with you for suggesting that they have migraine. And it can be a difficult and delicate topic. So, again, I think it just comes back to explaining here's what the criteria for sinusitis is, right? We go back to those 4 main symptoms, and I will walk through those symptoms with people. And, sometimes they'll be like, well, I'm a little congested, but I'm kind of always congested. Or I have a runny nose, but I'm not really blowing out really thick, discolored mucus. And so, I tell them, look, even with migraine, you can have these vasomotor symptoms because of, there's these little nerves. I don't necessarily call them out of what they are in clinic, but you guys know you've got parasympathetics that run with your trigeminal nerve. And the trigeminal nerve is really, that nucleus is the center for migraine pathology. So if you've got these parasympathetics that run with those nerve branches into your face, there are plenty of people who have migraine who also get congestion, who also get runny nose. Again, that doesn't mean sinus infection. So the appropriate term is actually rhinogenic headache and non-rhinogenic headache, but no one uses that term. Rhinogenic just means, okay, you have facial pain and we see pus pouring out of your maxillary sinus and you've had, some tooth sensitivity and we think this is truly a sinus infection, right? Non-rhinogenic, headache gets more into migraine or tension headache or things like that. And it's hard, I think, like I said, for people to hear migraine. I think most people don't want it to be migraine. Migraine feels hopeless. Migraine feels like they're in a category they don't want to be in. But I definitely have seen people who have gone through years of misdiagnosis and ergo mistreatment. And then once they understand what's going on and they wrap their mind around it and they change some routines and they work on, different things, or we have medications we do for this, they come out the other end of it and they're so much happier. They feel in control. I think that's a big piece of it. It's nice to be able to feel empowered and in control, that you know what's going on with your body and you know what to do if something feels off.
Yeah, absolutely. And you said, it sounds like you work really hard to empower your patients, which is really what most patients are asking for these days. They're inquisitive, they want to be heard, and they just don't want to be dismissed. But all of that's super fascinating, but not as fascinating as this next topic for me as a gastroenterologist. I love that like everybody's worried about the gut now. It's awesome. So let's talk about this gut sinus science, probiotics, prebiotics, and the gut microbiome and how that could be affecting people's sinus symptoms.
So I'll tell a quick story to why I even started thinking about this. And yeah, I feel like all the gastroenterologists these days are like, yeah, we knew that. Yeah. Like everybody's jumping on our bandwagon, but we've been talking about this for a long time. But so I had a patient, she was an older woman and she had been like literally to about 10 different ENTs before seeing me. She'd had like 6 sinus surgeries. I mean, just, been all the things. And she came in and she, her sinuses looked awful. And I was really at the point where I was like, look, we can go in and just do like a flush under some anesthesia, just like get everything really cleaned out and kind of try to reset things. She was like, okay, but I have this vacation I'm going to go on. Can we just wait to do after that? I said, yeah, that's fine. And so she came back in a couple months and she said, I know this is our pre-op appointment, but I feel really good. And I was wondering if you'd be willing to take another CT scan of my sinuses to see what they look like. And we did. And y'all, she went from like open sinuses surgically, but crowded with all kinds of mucosal thickening and gunk and mucus and pus. That was like her first one that I saw her with, to completely clear in a matter of a few months. And this was the time where my jaw hit the floor. And I was like, what did you do? And she said, the only thing I can think of is she started going and working with like a bariatric program. And she was like, I cut out alcohol. I cut out anything white and processed. I cut out sugar. And she was like, and I've just been eating really, really cleanly. And she's like, and I feel great, but my head feels great. And that was my, like, one of these light bulb moments where I was like, okay, I've got to learn more about this. So I did, right? But it's fascinating because even in the past couple of years, so much is coming out about the gut, connection to the rest of our body. Most people are familiar with like gut brain axis, but there's really a lot to be said for like the gut immune axis and that immune system kind of impacting distal sites like the lung and the sinuses. I mean, I think people forget that like your mouth and your throat are the beginning of your GI tract, and your nose and your sinuses are the beginning of your respiratory tract. So the gut impacts these through, direct and indirect actions. You've got metabolites like short chain fatty acids that are delivered from, the gut up to these areas. You've got, modulation of immune factors like T regulatory cells. Like, it's really fascinating to see those connections. Do we know enough to have a tried and true protocol to say, oh, for this, you put them on this probiotic and you tell them to eat this food? No. But in general, do I talk to my patients about fiber in their diets, the benefit of fermented foods? 100%, absolutely. Yeah. So it's, I find it fascinating, probably, maybe not quite as much as you, but I feel like I'm with you guys. I love it.
Love it.
I really love that. Yes. Well, we know that antibiotic use is so prevalent in medicine, and we always talk about how it's overly used with the antibiotics and that leads to problems. But what have you seen in the ENT realm, and why does it have you concerned about antibiotic use?
I'd say there's two main areas where it hits me in the face. And we've just spent, the past 20 minutes or so talking about the sinus problem, where people are coming in with, a working diagnosis of sinus infections, and they're getting repeated antibiotic courses from an urgent care or somewhere, telehealth. And yet they're absolutely not infections. They're allergy exacerbations, they're migraines, maybe they're viral infections that never needed an antibiotic to begin with. So that's a big one. And the reason it's a problem is for those patients that go on to develop true chronic rhinosinusitis, one, is there a link between the number of antibiotics they took and the development of that disease, right? If we've just said there's this connection and we know antibiotics impact the gut microbiome, then it kind of goes to follow that if you're damaging the gut microbiome with repeated antibiotics, that's going to have a downstream effect on your sinus microbiome, which then, can lead to more of that chronic sinusitis, sort of pathology. The other big area that I see, though, is ear infections. Again, not a knock on primary care. I love my primary care colleagues. I love, there's some urgent cares that I love here that they do a great job. But ear infections are notoriously misdiagnosed as well. And I think the the yearning, I think, from providers is good. It's, I want to help this patient and I don't really know what it is, but let me just give them an antibiotic just in case. Or maybe the patients are pushing for it and, they really want to be seen as a helpful provider, right? So I get the complexity of it. But again, adult ear infections, usually viral, usually don't need an antibiotic. Kids' ear infections over the age of 2, watchful waiting is recommended with pain management before you give an antibiotic. But yet I see so many people who, again, the third one with ears is external otitis. So like an outer ear canal infection, treat that with drops. You don't have to give an oral antibiotic for that. And again, it kind of comes back to, if that's what they've been treated with for months before they've seen me, those are the kids who they do finally get a set of tubes, let's say. But then those are the kids who go on to get biofilm problems around the tube, and they have chronic ear drainage even after the tubes are put in. And it's because their body's system, because of the repetitive antibiotics, have developed such a resistance that the bugs that they have now aren't responding to the typical ear drops, which work for most kids, right? So it's just kind of, it stinks because you're trying to help people, but you're also trying not to harm them in the long run. And really, to me, it just comes back to like, did we get the diagnosis right? And if we didn't, then who else does this patient need to see to make sure we do, that kind of thing.
Absolutely. Well, we've covered a lot of really interesting information today that I think is going to be a little bit of a bomb drop to some of our listeners, but what resources do you suggest our listeners go to for more information if they're suffering from a lot of these issues that you feel like could really be helpful?
I would say, trusted online sources. So I mentioned our sort of National ENT Society, which is the AAO-HNS. They have a website called enthealth.org, and it's patient focused. So you can go on there and you can search for any symptom or any disease, and it'll, give you a sort of easy to understand kind of summary. I always tell patients are going to search on Google. Don't tell them not to do that, right? They're going to do that. But tell them to look for sites like Cleveland Clinic or Mayo or very well-known, trusted, don't go on Reddit or a blog or something like that, except for my blog. Just kidding. But not really. No, I do have a website. It's integrative-enthealth.com. There is a blog on it. And I have a newsletter where I just try to pick topics that, people are interested in, and send something out once or twice a month. And, so I always try to tell people, look, I've actually written about this very question you have, and I'll send them the blog, things like that. I told you I love podcasts. And there's a ENT podcast called Backtable ENT. Some of the topics are really clinical, really heavy technical. So may not be popular with, everybody, but that's an option. And then, some of my favorite books I have behind me, my library of things, but Fiber Fueled is wonderful for gut health discussion. I love Matthew Walker's Why We Sleep, The Science of Immunity. These are all great books for people to kind of just get a better understanding of, how their body works and what promotes really, truly overall health.
Well, thank you so much for being here today. It's always fascinating to actually get to sit down with one of our specialists in these areas, especially for primary care, and be like, okay, give me some more tools I can use to have discussions with my patients about this. So for our listeners, don't forget to go follow Dr. Lee at ENT Chat on Instagram. She talked about her blog, her website. You can get in contact with all sorts of ways. It's great. We love this kind of information. But that is it for this episode of the MedEdit podcast. If you're a clinician, do not forget to check the show notes for CME instructions.
And as always, thank you for tuning in. And thank you so much for joining us today, Dr. Lee. It was super helpful.
Thank you so much for having me. This was great.
No problem. And follow us on Instagram and TikTok at the MedEdit Podcast, and send us your ideas for future episodes.
Thank you for listening to the MedEdit Podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Carrie Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit Podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Carrie Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.